morning everyone. As you all know that myself is Dr. Visharad Trivedi. I am working as an associate professor in cardiovascular anesthesia department in UN Mehta Institute of Research Center and Cardiology Center. We have discussed in the previous lecture that the principles of Veno Venous Ecmo and little bit about the history of Veno Venous Ecmo. As you all know that we have started an ECMO series right from the history and knowledge of types of ECMO from Dr. Jigisha madam, then Veno Venous Ecmo principles and history of Veno Venous Ecmo in my previous lecture. And so today, after putting a Veno Venous Ecmo, it is very important to manage that Veno Venous Ecmo as well. So today we learn about the management of Veno Venous Ecmo in broadly in two headings, that is circuit related management and patient related management. So first we'll see the circuit related management. So in circuit related management, first when you put a Veno Venous Ecmo, the first flow should be around 50 to 80 ml per dry kilogram of weight per minute of the patient. That is your first setting to be made on Veno Venous Ecmo. And then you can maintain the maximum flow, as we have seen in the earlier lecture, that if you want to increase the saturation, then you have to increase the flow, because oxygen delivery is mainly through the ECMO flow. So to maintain the saturation is around 80-85%. If you want to increase the flow, then you can increase the flow a little bit. Then you have to calculate the delivery of oxygen and oxygen uptake very frequently, and you have to calculate the ratio as well. If the ratio is less than 2, then it is inadequate. Then you have to increase the oxygen delivery by increasing the hematocrit or by increasing the ECMO flow, or our goal is to keep the ratio is more than 3. Oxygenation maintenance, oxygen management is also of utmost importance in Veno Venous Ecmo, because we have put an Veno Venous Ecmo just for the respiratory support only. So SpO2 is only usually roughly kept around 80-85%, may sometimes be roughly around 75 to 80%. So here comes the important concept of hypoxia versus hypoxemia, as we have discussed earlier in the lecture, that you have to maintain the good amount of hemoglobin or hematocrit, so that even with the low saturation, your oxygen delivery to the tissue should not be hampered. Now, one of the important factors in such situation is if the patient is kept in the ICU and his saturation is around 80-85%, then you have to train the ICU staff, ICU sisters as well, to keep looking this 80-85% saturation as a normal, and don't do anything extravagantly to increases the FiO2 or to increases the saturation as well. This is a normal for Veno Venous Ecmo. CO2 removal is controlled by sweep gas flow rate, which we have seen in the earlier lecture with the graphical presentation also. So initially when you start a flow, you have to keep a sweep gas flow at the ratio of 1:1. That is, if you have start the flow with 5 liters per minute, then you have to keep sweep gas flow at 5 liters. Depending on the PCO2, you have to maintain the PCO2 around 40-45, and it can be increased as high as 1:15 or 15 liters per minute of sweep gas flow as well, just to remove the CO2. One of the very important aspect of management of Veno Venous Ecmo is anticoagulation, of course. In anticoagulation, first and foremost is heparin. You have to give heparin, continuous heparin in a dose of 50 to 100 units per kg. Once bolus at the time of cannulation, and then continuously infusion. You can maintain the anticoagulation with regarding to the ACT or APTT. ACT should be kept 1.5 times normal, or roughly you can say the ACT should be kept around 180 to 200. ACT should be measured bedside and every 2 hourly. Infusion of heparin should be kept at 10 units per kg per hour, and depending on the ACT changes. There is no standard dosing of heparin as such, because the relatively efficiency of the heparin in every other patient is differing. So depending on the ACT values, you have to change the dose of the heparin. WBC and platelets can affect the clotting, so APTT should also be looked for, and desired level of heparin concentration in blood is 0.5 units per ml. That is not relevant as such. Thromboelastograph can be useful in case of severely bleeding patients, because bleeding is a major complication in Veno Venous Ecmo. Another coagulation factor should be also measured, like antithrombin 3. Its level should be kept around 80 to 120% of the normal level. If there is low level of antithrombin 3, then you can replace it with a recombinant antithrombin 3, FFP or cryoprecipitates. Heat syndrome can be caused by a long duration on Veno Venous Ecmo after more than 15 days and prolonged heparin infusion. Then it can be a diagnosis of exclusion. Then you have to stop heparin, and heparin substitutes can be used for such patients. Another important factor for anticoagulation is platelets. You have to maintain the platelet levels. Thrombocytopenia is a major cause for bleeding in Veno Venous Ecmo. Thrombocytopenia is very common in Veno Venous Ecmo just because of the primary disease of ARDS or lung pathology, or drugs which you are giving like heparin, milrinone and all that stuff, and other adsorbents agents which can cause thrombocytopenia by exposure to the surface, blood surface, extracorporeal surface. If platelet is less than 20,000, then chances of spontaneous bleeding is very high. Goal is to keep it around more than 80,000 so that the chances of bleeding will be reduced. Another important factor is fibrinogen. You have to measure it continuously daily. Actually, for daily, you have to keep it around 250 to 300 milligram per deciliter. If it is less, then you have to replace it with the FFP or recombinant fibrinogen. Surface coatings may be used with the newer available circuits in which there is a coating of heparin or other polymers like heparin and chondroitin, which is not a substitute. Actually, which is not a substitute for anticoagulation. You have to replace it with the heparin also. If at all you are using a heparin coated circuit, then also you have to give heparin. Circuit monitors and alarms should be checked every day basically. One of the very important alarm is high pressure alarm. In case of kinking or in case of clotting or in case of some kind of obstruction, there should be a high pressure alarm obstructing the flow to the ECMO circuit, which should be kept around 400 millimeter of Hg, which is a safe level at the highest level. Air in the circuit can be also seen from the bubble detector. Clotting can be seen by the flashlight. Electrical power failures can be very cumbersome in case of VV ECMO, so your hand shaft should be always ready. And if there is electrical power failure in your ICU, then you have to keep in mind that the heat exchanger or water bath is using a maximum power, so you should keep it off at the time of power failure. Decannulation, sudden decannulation can be a cumbersome complication, so that you have to secure your cannulas at the two sides. Hemolysis is very common in ECMO, particularly at a very high RPM, and at a very high vacuum pressure of more than 300 mm of Hg. So you have to balance it accordingly according to the risk of the hemolysis. Emergency drills should be kept every day, or at the time when there is no patient, you have to also start doing emergency drills with your ECMO team. Component and circuit changes should be done within as fast as possible, done within 1 minute. Proper order should be followed. So here comes the importance of emergency drills. And before stopping the ECMO flow and to change the components, you first have to put the patient on ventilator with a maximum settings and maximum FiO2. Traveling is very actually prohibited during Veno Venous Ecmo, but if at all is needed, you have to be fully prepared with a proper schedule. Now these all are the circuit related management. Now we switch our attention towards the patient related management, how we should manage the patient while the patient is on Veno Venous Ecmo. So first and foremost is you have to maintain the hemodynamics. As you all know that we have learned in the previous lecture that Veno Venous Ecmo is not providing any support to the hemodynamics. So your inotropes or supports for the arterial pressures and cardiac pressures should not be stopped as in Veno arterial ECMO. So Veno Venous ECMO is purely a respiratory support, and so same dose of inotropes, vasodilators as well as blood volume replacement should be continued. If at all while patient is on Veno Venous ECMO and patient develops cardiac failure or patient develops right ventricular failure because of lung, then you have to switch Veno Venous ECMO into Veno arterial ECMO. Ventilator management is of importance in Veno Venous Ecmo, as we have seen in the previous trials that till the Caesar trial, all of them are using a very high tidal volume and lung damaging ventilation strategies. So the Caesar trial success is also depending on the ventilatory management as well on Veno Venous Ecmo. So first of all, when you put the patient on ECMO, Initially you have to keep it a very high FiO2 right at the time of cannulation, just to prevent the complications. After that, our goal is to keep the FiO2 less than 40% and plateau pressure should be less than 25%, no matter whatever amount of tidal volume should be going. So that is actually a lung protective strategies. So in first 24 hours, you have to keep the patient moderate to heavily sedated. Pressure control ventilation should be kept at 25 inspiratory pressure with 15 of PEEP. Inspiratory expiratory ratio should be at 2:1 with a respiratory rate of 5. FiO2 of 50% should be kept and plateau pressure should be less than 25%. So these all are parameters of basically a lung protective ventilation. If initial PCO2 is 50, more than 50, then you have to increase the sweep gas flow. So you have to keep the PCO2 around 40-45 to maintain the pH, and you don't have to increase the ventilatory settings to remove the CO2. After one day, after 24 to 48 hours, if the patients are showing stable hemodynamics and if there is no requirement of any vasopressors or any hemodynamic management, then you have to reduce the sedation. Minimal sedation should be required just to tolerate the cannulas. Reduces the ventilatory support as well of 20 to 10. I ratio should be kept at 2:1. Respiratory rate is around 5 and FiO2 is 20 to 40%, 21 to 40%. After 2 days, you have to actually start to try to wean the patient from the ventilator, and you can also extubate the patient if hemodynamically if he is stable. If patient is not extubatable after 3 to 5 days, you have to think over for tracheostomy. PCV, that is pressure control mode, as we have seen in the previous day, that is 20 to 10 should be continued, and intermittently you can also give a trial of CPAP also with a 20 inspiratory pressure support. Recruiting trial intermittently should be done just to prevent the lung collapse and lung recruitment. So but it should not be started until you are seeing that the lung aeration is improved in chest x-ray, and if tidal volume is more than 4 ml per kg with the same settings without increasing the settings. You can perform a Seeley's test, that is increasing the FiO2 to 100% right from the 40%, and see for the rapid increase in the saturation of 100%. If it is there, that means that now the lung is taking part in gaseous exchange, and now you can slowly and steadily wean the Veno Venous Ecmo as well. So once the Seeley's test positive, you can start your recruitment maneuver with a CPAP of 25 and with on spontaneous, or pressure support ventilation of 25 inspiratory pressure with 10 PEEP, and inspiratory expiratory ratio of 3:1, that is inverse ratio ventilation for 10 minutes per hour. You can decrease the ECMO support as the lung function is improved. Airway access is mainly intubated initially. As I have already told you that if patient is not extubatable within 3 to 5 days, you can think about tracheostomy. But to carry out a tracheostomy on a Veno Venous Ecmo with full anticoagulation is very cumbersome procedure, and bleeding may cause a severe torrential hemorrhage in the trachea, and that may lead to or more gaseous exchange difficulties. So you have to use it judiciously. Now, as we have earlier seen that the returning blood which is coming from the ECMO is fully oxygenated with 100% oxygenation, and it carries of PO2 around 500 mg with a saturation of 100. So oxygen content of that blood is around 22 ml per deciliter, while the returning blood, which is normal venous return coming to the RA, is having a PO2 of 40 and saturation of 80%. So the ratio of mixing between returning blood from the ECMO and returning blood from the systemic venous return is around 3:1. So what you are getting outside into the system from the RA to right ventricle is oxygen content of 17 ml per deciliter. If the native lung is functioning, so this blood will go into the pulmonary circulation, and this native lung will also take part into the gaseous exchange, then that will increase the further PO2 more than 80. So till 80 it is mostly because of the ECMO gaseous exchange, and after that if it is more than 80, then it is through the native lung gaseous exchange. You have to, as again I keep on emphasizing the fact that if PO2 is on the lower side, saturation is on the lower side, then you have to maintain the hematocrit more than 40 for a good oxygen delivery. Sedation, for maintenance of sedation, I have already told you that at the time of cannulation you have to completely paralyze the patient so that to prevent the venous air embolism. After that, for initial 1 day you have to keep it moderate to heavily sedation. Then you have to completely start to reduce the sedation and try to make the patient awake. On the very next day, on the very second day, you have to keep it at a minimal sedation, and then from the third day onwards you should start to remove the sedation as well as start to try to extubate the patient as soon as possible. This is a very important topic of management of total volume, because as you put the patient on Veno Venous Ecmo, the whole of the priming volume in the ECMO circuit comes into the systemic circulation. So goal is to keep the adequate hemoglobin, because once the dilution is there, your hemoglobin falls and oxygen delivery also decreases. So goal is to try to maintain the normal hemoglobin, hematocrit and normal body weight. So initially for 1 day, blood volume is actually getting doubled or tripled once you put the patient on venous ECMO, but this crystallized gets easily equilibrates with the blood within 1 or 2 days. So blood volume should be adequate enough to have a adequate drainage in the venous side also. So your CVP should be kept around 5 to 10 mm of Hg. If your CVP will drop, then your suction force on the venous side also increases, and that may cause hemolysis as well with venous chattering. Achieving normal ECF status in first 12 hours is very difficult, but after that you have to maintain the normal ECF status. If urine output is not there, if patient is not passing urine output because of sepsis or because of any other reason, then you have to straight away go for veno-venous ultrafiltration, hemofiltration, just to maintain the good normal euvolemia. If you try to maintain the hemoglobin on the very higher range, then your flow requirement should be low, so that your venous volume should be low, also can be tolerated very well by Veno Venous Ecmo. Temperature can be easily maintained by water bath, usually kept around 37 degrees centigrade. If patient has any complication or any neurological problem, brain injury or like that, then you have to keep it moderate hypothermia in the range of 32 to 34 degrees centigrade for 1 to 2 days. Renal and nutritional management is also of utmost importance once you try to ventilate and extubate the patient after third day. So if patient is passing urine, then it's well and good, you have to maintain the euvolemia. If he is not passing urine, then you have to straight away go for CVVHF, continuous veno-venous hemofiltration, and try to maintain the euvolemia. Caloric and protein requirement should be measured and provided as in the other patients of the ICU. Infections and antibiotics are of utmost importance, because so many lines are there invasively put in the patients. So cannula sites are cleaned frequently with antiseptic solutions. But however, in this set of patients, if you find the blood culture is positive, then you should not, you don't have an option of decannulating right now. Right at that point of time, you don't have the option of removing the source of the infection right at that particular time, until unless the patient is severely septicemic. So try to maintain the antiseptic environment and provided empirical. There is no actual empirical antibiotic therapy should be given in Veno Venous Ecmo, but if you suspected any infection, you have any culture, then you have to give antibiotic according to the culture report. Positioning of the patient is of importance for initial 1 to 2 days, because after that patient, if patient is extubated, then you have to try to keep mobilize the patient to prevent the DVT and collapse of the lungs as well. Bleeding, which is the most dreadful complication on Veno Venous Ecmo, because we are trying to maintain the anticoagulation on a little bit of a higher range. ACT should be kept on 180 to 200. So bleeding is very common complication. Bleeding can be through any and every mucous membrane. Can be from the chest tube placement, can be from the uterus, GI bleed, head and brain, can be from the head, can be in the intracerebral hemorrhage can be there because of a low platelet. Any and every possible site can bleed on Veno Venous Ecmo. So in case of bleeding, try to reduce the anticoagulation and maintain the coagulation status as normal as possible after stopping heparin and all the anticoagulation. Try to replace the FFP, cryo, platelets and antifibrinolytics, and try to maintain the euvolemia and stop bleeding. Once the bleeding is stopped, then again you can resume your anticoagulation regime. If you want to do any procedures on Veno Venous Ecmo, most common procedure to be done on Veno Venous Ecmo is tracheostomy itself. So, but you can choose, you can do whatever you want on Veno Venous Ecmo, right from the vena pincher side to liver transplantation. Coagulation should be optimized at that particular time, and use of electrocautery is utmost importance to prevent the bleeding post procedural as well. So if you try to do a tracheostomy on Veno Venous Ecmo, do not incise a tracheal ring or create a flap. Just field should be your bloodless once you do a tracheostomy. So after all of this management, if patient is maintaining well on Veno Venous Ecmo and if lung starts to improve, then you have to think about weaning of Veno Venous Ecmo. So when you, at what point of time you should start thinking about weaning of Veno Venous Ecmo is when extracorporeal flow is less than 30% of the total, then the lung function may be adequate to come off. So basically when you start the ECMO, your flow is 100%, and if the flow requirement is less than 30%, even if after that patient is able to maintain the gaseous exchange with native lung, then it is a time for you to wean the Veno Venous Ecmo. So once you think that the patient can be weanable, then you have to give a trial of. What is trial of? We'll see in the next slide. So as long as the support is 30 to 50%, then you should not give a trial of. You should not think of weaning. First, let the lung completely recover, let the ECMO flow less than 30% of the total, then try to wean the ECMO. So you can wean the Veno Venous Ecmo in two different ways. One is you can reduce the flow gradually. Gradually you can reduce the flow while you are maintaining the FiO2 of 100% on sweep gas, so that your oxygen delivery will be reduced. So this is one of the method. Or the second method is you can maintain the flow at 2 liters per minute but gradually reduces the FiO2. That also reduces the oxygen delivery, so by these two mechanism you can wean the Veno Venous Ecmo. Both mechanisms are equally good. No, whatever you choose to wean, method you choose to wean is appropriate for the patient. Stable saturation on adequate ventilatory settings on trial of. Okay. Then you can clamp off the sweep gas flow so that your gaseous exchange is not occurring at the oxygenator level, and even after that if patient is able to maintain the gaseous flow, gaseous exchange, that means you are now ready to remove the Veno Venous Ecmo. Now what is trial of? If the trial of is basically through which the native gas exchange is tested, the lung is recovered or not, that you can test by trial of. Adjust the ventilatory setting you would accept after coming off. Once the Veno Venous Ecmo is off, then whatever lung protective strategy is there, you please put your ventilation in that setting. Then maintain the blood flow and anticoagulation. Stop the sweep gas flow so that there is no gaseous exchange on the oxygenator side. Wait for 1 hour and again do an ABG. If the ABG is adequate, ABG is appropriate, if PCO2 and PA2 level are acceptable, then your trial of will be successful. If trial of is successful but the patient is precarious, then you have to keep the cannula in place. You have to recirculate the blood in a Veno Venous Ecmo circuit, but for 24 hours, so that if patient deteriorates again, then you have to again go on Veno Venous Ecmo. So after weaning, after removing of the cannula, after removing of the Veno Venous Ecmo, you have to decannulate the patient. So decannulation can be done as a method of as the patient is cannulated basically. So if percutaneously cannula is inserted, then you have to remove it percutaneously. If direct cut down technique is used, then you have to remove it by the direct cut down. Valsalva manual on the ventilator or the patient himself, if the patient is extubated, should be used to prevent any kind of venous air embolism. So once there is a decannulation, you should keep the patient on normal ventilatory support, or if the patient is extubated, give a minimal amount of FiO2. So this is one of the important concept for Veno Venous Ecmo, that is stopping support for futility. So if there is no hope for healthy survival, brain damage, no heart or lung recovery, or no hope for any organ replacement. So basically in sense, if the damage is irreversible, then it should be explained to the family. Recovery deadline should be set upfront. Whenever you are putting a Veno Venous Ecmo, or for that matter Veno Arterial Ecmo, you should have in your mind the recovery deadline. Mostly for cardiac failures it is around 3 to 5 days, for lung failure it is around 15 days. But of course exceptions are always there, as you have seen in the COVID also. Many patients have come off from ECMO after 100 days also. So but you have to set a recovery deadline initially upfront, so that if after that recovery deadline, if patient has no signs of any recovery, then you have to explain the family and stop the supports for futility. If nowadays the newer diseases emerges in which we can use a Veno Venous Ecmo, and newer protocols are also adjusted for such diseases, like if the patients are having lobar collapse or mucus plugs on X-ray, then you have to go for bronchoscopy while patient is on Veno Venous Ecmo. Large air leaks or large bronchopulmonary fistulas can be operated on while the patient is on Veno Venous Ecmo, or you can put the patient on Veno Venous Ecmo just to treat these large air leaks. Selective CO2 removal also we have seen in the previous lecture that that can be used for removing of the CO2 which is not removed by the native lung exchange. Pulmonary embolism associated with right ventricular failure, massive embolism can be managed by Veno Venous Ecmo initially, and if there is RV failure, then you can switch over to VA Ecmo as well. ARDS from secondary lung injury also should be managed by Veno Venous Ecmo. Veno Venous Ecmo is major modality of treatment in ARDS. Fluid overload is per se is not an actual indication or actual disease for Veno Venous Ecmo, but you can manage it if the patient is not responding to conventional therapy. Now after ECMO removal, there is also you have to maintain the ventilatory management as well as gaseous exchange through the native ICU period as well, because if there is a recurrent infection or recurrent respiratory dysfunction, then you have to again land up into complications. So after ECMO weaning, ventilatory setting should be continued as per the institute protocol, mostly the lung protective strategies. Tendency to drift towards positive balance, more sedation, increasing ventilatory setting should be avoided. This is very important. Once you have removed the ECMO and again patient deteriorated, don't try to increase the ventilatory setting just by just to maintain the saturation or just to maintain the vitals. In fact, if patient is deteriorated, go again back on Veno Venous Ecmo, so that the patient should be managed easily. If tracheostomy was not done previously because of the risk of bleeding, then you have to do it right after the weaning of ECMO. Alveolar dead space in necrotizing pneumonia or high plateau pressure can be increased because patient was remaining on the very high inspiratory pressure and high plateau pressure throughout this ECMO period. So there is a chances of increase in the alveolar dead space. So you have to keep that in mind also. Usually after Veno Venous Ecmo, the lung function resolves within 1 to 6 weeks. 10% of the patients are after removal of the ECMO will die in the hospital itself because of the secondary complication as well. Some patients need home ICU care and ventilatory care in the home as well for 24 hours even after removal of the ECMO. So even after removal of the ECMO, you have to keep a very vigilance on the gaseous exchange as well as other systems or secondary complications of the ECMO as well. One of the very rare diseases are also upcoming in also registry, for which the ECMO now is a treatment of cure, like in ARDS also. ARDS is a pioneer treatment for ARDS is Veno Venous Ecmo. So nowadays new modalities, new diseases also arises in which you can use Veno Venous Ecmo as a treatment, like vasculitis, autoimmune lung diseases, bronchiolitis obliterans, Guth-Pasteur syndromes, and some bacterial or viral infections in which there is reversibility. Now what till now in the last 10 years total 13,000 cases were recorded in Veno Venous Ecmo according to the ELSO registry with a survival rate of 58%. So our expected result should be, when you put a Veno Venous Ecmo, 60-70% of survival rate should be there if you put it in a good indicated patient with and manage it well with a proper hemodynamics and circuit management. So what you need in the future is you need a prospective trial, but conducting a prospective trial in a ECMO is very problematic because of the study design, ethics and interpretation. A total 11 prospective trials are undergoing right now, and likely future trials are will be there, which comprises that the ECMO, if instituted early or late in severe respiratory failure, will change the outcome of the patient or not. Thank you. Thanks a lot.